we now want to move the colloquium into the next phase, which would be to say, okay, if we really want to tackle population health problems, how do we do that in this kind of institution? What kinds of ways can we tackle these complex problems and move forward? And so what we're going to do now is talk about 3 examples where we already are doing something on complex problems. These complex problems are going to be cancer, which is now the #1 cause of death in San Francisco and surrounding areas. We're going to talk about food and food insecurity, which is another complex problem. And we're also going to talk about infant mortality and preterm birth, the Preterm Birth Initiative. So these are 3 examples of these kind of big complex problems. What are we already doing? How can these examples model what we might do moving forward? So the first speaker is going to be Tung Nguyen, my friend and professor of general and internal medicine. He, as you know, is one of the Dean's diversity leaders, and he's going to talk about the San Francisco Cancer Initiative. So I'm going to ask him to come up as I introduce Laura Jalif-Pawlowski, an associate professor in epidemiology as well as me. And she's the director of Precision Health and Discovery for the California Preterm Birth Initiative. She's going to talk about that initiative. And then finally, Hillary Seligman is going to talk about food insecurity. She's an associate professor for medicine and epidemiology and director of food policy, health, and hunger program for the Center for Vulnerable Populations. So listen to what they're doing and think about your own work in the sense of affecting population health. Tung?
Thank you, Bob. Actually, Bob and I decided that he should be presenting this, but it turns out that he wants me to present it, and he's my boss, so I got to take what he says. Also, for those of you who are tweeting, hashtag UCSF Pop Health is trending, so jump on it. So I'm here to present a San Francisco Cancer Initiative. I was actually, Dr. Galia's presentation is incredibly thought-provoking. I was trying to reorient what I was going to say on what he said, and that's always very dangerous as a speaker, so I'm going to stick to my script for a minute. So this is actually a major undertaking that has been spearheaded by our Cancer Center director, Alan Ashworth, who parenthetically is a basic scientist. And he's one of those very valuable allies that you need in population health, a basic scientist who's incredibly accomplished, but who gets population health. He understands that his work does not mean anything unless it is implemented across the population. And along with him, Bob Hyatt, who's the Cancer Center's Associate Director of Population Sciences. I'm here because I'm a member of the steering committee of this initiative. We got 3 slides, by the way, so just wanted to let you know that when they look like this, it's not my fault. Just a little bit by way of background, cancer is the #1 cause of death in San Francisco. We know that cancer prevention and early detection can have a significant impact on cancer incidence, mortality, and inequities. And we also know that up to about 50% of cancer mortality can already be prevented what we already know. All right, that's really important for people working in an academic research center to understand, is we're working on the other 50%. Pop health people are actually trying to get what's already known into the field. So as a result, we have an opportunity to implement what we know with greater precision and greater impact if we take a more ambitious approach. So the question that the San Francisco Cancer Initiative wants to answer is, what might a comprehensive, integrated, precisely directed, transdisciplinary approach to cancer control look like in a major U.S. metropolitan area? So why do we want to answer this question? Because the ambitious goal of the initiative is to reduce the cancer burden and inequities in incidence and outcome by applying evidence-based interventions, new technologies, and our knowledge of all the needs of all the residents of San Francisco. So this is a list of a partial list of the partners that are working on this goal. And I think, the main thing about this slide is that complex problems needs complex solutions, requires complex groups of people working together. We acknowledge that an ambitious goal like this cannot be done by an institution as great as UCSF alone. And so this partnership list includes, and we put in the middle, the city and county government of San Francisco, because we don't think that anything can be done without engagement of the policymakers. Department of Public Health, Tomas is here, major medical organizations such as the American Cancer Society, the Hospital Council of Northern and Central California, and San Francisco Medical Society. We also have this ambitious idea of integrating all of the healthcare system in San Francisco to work together, not as competitors in the marketplace, but as people who are devoted to improving the health of every resident in the city. So, for example, we have Chinese Hospital, Kaiser Permanente, the Community Clinic Consortium, and many others. We are also engaged with multiple community organizations in San Francisco. We know that this cannot be done without the engagement of the various community organizations. I would just want to highlight SF-HIP, which actually is San Francisco Health Improvement Partnership, which was catalyzed by the UCSF CTSI's Community Engagement and Health Policy Program, represented by Kevin Grumbach here. Again, these are things that we did during other kind of grant funding, but now we're trying to bring it all together in this bigger, complex intervention. So what is that we're trying to do? So we're trying to reduce the burden and inequities of cancer through the implementation of precision population health and using a collective impact model. So, as I said, we can't solve these complex problems without a transdisciplinary approach, which requires a wide range. And when we say transdisciplinary in this institution, we tend to think about things like public health and medicine and anthropology and so on and so forth. What we mean here is more than that. It's beyond the academic expertise. We also need to involve the various sectors of society. And in this collective impact model, UCSF is simply the backbone organization. We link everybody together, try to come up with funding along with them, identify the issues, collect solutions from everyone, and try to make sure it's implemented and coordinated. The idea of precision population health, which I think many of you are familiar with, is really based on the concept of targeting appropriate interventions to the appropriate groups. This may be genetic, as is classically defined by precision medicine, but it can also be cultural, linguistic, socioeconomic, and other domains. This is what we call a genes to society view of the determinants of cancer and how we're going to intervene on it. So one key function for SF-CAN is to track cancer incidence, mortality, trends, disparities, and costs for the city. That has been really helped by having the greater Scarlett Gomez from the Greater Bay Area Cancer Registry come here to UCSF. That's really increased our ability to map out individual cancer in individual census tract in San Francisco. So, for example, the task force that I work on is the liver cancer task force, and we are able to say, how many cases of liver cancer occur in Chinatown? How many cases of liver cancer occur in Bayview, Hunters Point, and the Mission? And those are actually the 3 neighborhoods with the highest rates of liver cancer in San Francisco. Knowing things like that will allow us to be able to think about how to impact, for example, the incidence of those cancer and inequity associated with those cancer. And through our task forces, we also obviously want to implement evidence-based and I say and/or, innovative interventions to make a measurable difference. We, of course, want to use what's evidence-based. But, of course, absence of evidence is not evidence of absence. Just because something hasn't been shown to work and our community thinks it might work, we're obligated, I think, to at least pay attention to that and think about it. And even though SF-CAN is actually not a research program, we will use what we learn as a way to create answers that are more relevant, that lead to more relevant and more impactful research questions. This is actually the flip side of what we talk about when we talk about the roadmap, the translational and implementational science. We're not going to sit in the room and in the office thinking about how to create projects that are translated or implemented. We're going to go out there and try to implement and change and then find out what's missing and come back and design research projects to deal with this. My last slide. Currently, we have 5 task forces, and for more information, go to our website, sfcancer.org, very easy to remember. I want to briefly highlight one accomplishment from each of our task forces, which is where the work is done primarily. These are very, you can't read this, but this is the website. So this is the breast task force. And they have convened multiple stakeholders and leaders of programs to improve mammographic screening and follow-up among the most disadvantaged groups in the city. So they are, starting to use this geospatial technologies and cancer registry data to localize the area. So for example, the idea would be, once we know who's getting mammograms and where the incidence of cancers are, we can then think about, well, where do we need to send more information about mammography? Or where do we need to send the mobile mammography van? Or, there are things that we're talking about in terms of more personalized breast cancer screening studies that we're doing as well. The Colorectal Cancer Task Force has conducted surveys that show the lowest screening rates in the safety nets SF consortium clinics, and so we're now helping them to develop systems to improve their colon cancer screening rates, tracking, and follow-up. The Liver Cancer Task Force, which is the one that I'm helping to run, is collaborating with two community coalitions, SF Hep B Free and NHEP CSF. I just want to highlight the name of those two titles, SF Hep B Free and NHEP CSF. These are community organization coalitions, and they came out of the gate swinging. We're going to end Hep B in San Francisco. We're going to end Hep C in San Francisco. They're not afraid of making the ambitious move. And we're working with them because they know what's going on in the community a lot more than we do. So we're trying to address the major determinant liver cancer, viral hepatitis B and C. We're supporting the Department of Public Health's effort to track the cases and how they are being managed. We're supporting NHEP efforts to obtain major grants to promote screening and for the treatment of hepatitis C. So one of the functions that the task force actually does is to help pay for grant writing. So in a way, even though we're not doing the work, they know what they're doing. We want to help them get the money to do the work. And then also a patient navigation program for patients with hepatitis B. The Prostate Cancer Task Force actually takes this one idea that Dr. Galea has mentioned about looking at quality versus equality. Okay, so rather than looking at prostate cancer as quality improvement for everyone, since prostate cancer has a huge disparity among African Americans, the task force is focused on African Americans and prostate cancer disparities. So they're working currently on developing guidelines for PSA testing on African American men, in particular in clinical situations, to address the issues around benefits and adverse consequences of screening. And then finally, the Tobacco Cause Cancer Task Force, I think this is the title, or it's on the website. I don't know whether you came up with that title, Stan, or no? No, you didn't. Okay. And he can speak to it, but he...
I would have called it Fight Evil.
Fight evil. Okay, all right. That's our motto, fight evil. This task force, they have applied their research on menthol and flavored tobacco products to provide the science to support the SF ordinance to ban these products in the city. So again, when we're thinking about practical ways of implementing some of the things that we're talking about, academics can work with community organizations and policymakers to create policies that address underlying causes of these problems. There is an election going on, by the way. I'm not allowed to tell you which the way to vote for, but the evil is coming, it's fighting back, apparently. So, the
tobacco companies want a no vote.
Okay. The tobacco company wants a no vote on Prop E. So, thank you. That was good. I'm learning. The task force also developed programs to support tobacco cessation behaviors in youth and young adults, as well as substance abusing and homeless population in San Francisco. So I'm encouraging anyone who's interested in hearing more, learning more, to contact me and check out our website. Thank you very much.
Afternoon, everybody. I see people are leaving in drones, but stay. Or come back. I will echo that for Kirsten. So thank you so much for inviting me. I'm I want to talk a little bit about the Preterm Birth Initiative. And for those that haven't heard about the Preterm Birth Initiative, almost 5 years ago now, we were lucky enough to be the recipient at UCSF of the largest gift to address preterm birth ever received by any institution. And that was due to some visionary thinking by Mark and Len Benioff and Bill and Melinda Gates, with sort of this increasing understanding that preterm birth is associated with the highest levels of death in kids less than 5. But also, most importantly, is how can we do discovery and translate it into solutions the most rapidly. And one of the ways that we began to tackle this problem was to think about how preterm birth research had been done historically. And one aspect of that is thinking about place as innovation. What I mean is, if you look in the research on preterm birth that's been done, there's been a lot looking at sort of environmental factors across the United States, or drug and alcohol use across the world, or anemia across the world, and I could go on and on. And so this idea of, if we look at preterm birth in specific places and think about a lens that both includes cellular focus as well as a focus on the community and the environment, might we unlock some solutions? So our 3 communities in the United States have been Oakland, San Francisco, and Fresno. And then also in East Africa, we're focusing in Uganda, Kenya, and Rwanda. So when we started this work, given my frame, I thought, well, we're going to make discoveries in the United States that then we could translate over to Africa. And what we're learning, and you can imagine how do I say? That's ridiculous, right? But the idea that we have all the answers and what we're going to do is discovery here, and then we're going to go to Africa and we're going to fix things. And what we're learning, of course, and people could have told us this from the beginning, is even at the most cellular level, we're learning things in Africa that are informing our work here. So really, place as innovation, and having this African arm and this California arm, and thinking about how we can translate both at the cellular level and at the community level, both directions. So we have an East Africa arm and we have a California arm, and for the most part, those efforts go forward fairly independently. Our California arm, the PI on that is Larry Rand. Our East Africa arm, the PI on that is Dilys Walker. We get together every year. You can see the upper picture is our first meeting in Kenya. We had a great meeting around World Prematurity Day this year. And so we all get together and we talk and we share ideas. Specifically for the California discovery efforts, which I want to focus on just a little bit because I think is relevant to folks in this room, is we've really worked to develop a very robust discovery collaborative. And what I mean by that is not only do we cross 10 different departments at UCSF and many universities across the country, but you can see with the little light blue circle around it, those are partners that not only do we have a senior investigator, but we're making sure that we're funding postdocs and other individuals in the group, so that we're not just funding sort of the senior people, we're trying to fund the engine and bring that thinking back. And I will say those postdocs we've learned so much. We sort of had a hunch, right? If we put all these postdocs together, whether they're doing metabolomics or they're doing environmental factors, that will stem sort of this, all of this energy around new ways of thinking, and it really has turned out that way. But our collaborative also includes many community-based organizations in our 3 geographies in California, as well as hospitals and clinics. But you can see that what I think is the most important is our community advisory group. And so we work very, very closely with women in all 3 of our communities. And I like that first picture. It's really nothing about us without us, right? And we take that very, very seriously. And we're learning all the time. How does that look when we're talking about, say, molecular work? But that second picture are really our community advisory board and community members reviewing research protocols, setting research priorities. And then finally, that last picture is from our community innovation Innovators program, where they, for instance, a group of women in San Francisco decided to put together a research project that looks specifically at housing and preterm birth. So not only are women and communities involved in sort of advising us and advocacy, but really actively involved in reviewing research protocols and actually doing research themselves. So from a discovery point of view, and many folks have said this, and I will say even this morning or earlier today, I think we all at UCSF probably need to come up with a way we think about this together. We call it cell to society, but it's the same idea, really. How can we look at cellular factors, whether it's the metabolome, the genome, at the same time that we're thinking about community and families, with the idea of identifying what we call precision-focused interventions. Those might be traditional medications, et cetera, but they could be policies. They could be just small working groups of women in housing communities. The point is, how do we think about interventions more broadly? Also thinking about the new medications and the new tests that we want to develop, but also thinking more broadly. We do a lot of work in our group with very large databases. So for instance, of 4 million plus births around the state of California over many years, so we can look at patterns of preterm birth. But we also do very deep dives. So what I mean by that is, our data is not only very long in terms of the number of individuals that might be included, but can be very wide. So on some women, we look at genomics, metabolomics, proteomics, lipidomics. But the most important thing is that when we do that, we also know a lot about these women and with these women about the communities in which they live. So I want to highlight a few of those projects that we're super proud of, but also that illustrate sort of the cell to society. Brittany Chambers, who just joined the Department of Epi, has done some amazing work on structural racism and thinking about new ways to look at population densities and economic disparities and their risk of preterm birth and poor pregnancy outcomes. Matt Pentel, who is here, is doing some amazing work around housing and preterm birth. We had a lot of press last year on some of the work on insomnia and preterm birth that Jen Felder and Eric Prather are leading. That work is now not only looking at what's the association with preterm birth and insomnia, but what might be the cellular underpinnings. And then Alyssa Epples doing a lot of work on telomeres, some new findings that we're just moving into press on that. And then we work a lot, for example, with Joe DeRisi on pathogens and how they might be affecting preterm birth. And then finally, I want to leave with sort of introducing you to our solar study. This is how we hopefully will take the discovery work and move it into solutions. This is a study of 1,000 women in Oakland, 500 Black women, 500 Hispanic Latino women. It's really the brainchild of Monica McLemore. And PIs include myself, Brittany Chambers, and Anu Gomez at Berkeley, and we're doing a lot of measures around psychosocial stress and racism at the same time that we're looking at cellular underpinnings. So there's a website for that. We're currently recruiting for the pilot. We hope from the pilot to move into the full study, but hopefully this gives you a little bit about our arc.
So I want to start by thanking you for a really thought-provoking discussion, and I'm hoping on the fly to use some of your language because I think that the language gives me a really coherent background in which to understand the work that we do in the space of food insecurity. And for those of you who are not so familiar with food insecurity, about 12.7% of the US population doesn't know where their next meal is going to come from or is at risk of not knowing where their next meal is going to come from. This is a household level condition of inadequate access to food. We know in this country that nutritious food costs more than poor, calorically dense, but nutritionally poor food. And we know that the less money you have to spend on food, the more likely you are to have poor dietary intake. And that's really highly associated as a ubiquitous cause with obesity and diabetes, some of these epidemics that you are talking about today. So my work, with the work of my team, has really focused on how we address a ubiquitous cause, poor dietary intake, in a very low-income community, and how we hope to have an impact on a really complex problem within the scope of our own lifetime. And that has really been a lot of what has driven me to think about the work that we do in the context of working at scale. And the three main ways that I've identified to try to do this is to work through partnerships, to work through policies, and to be very intentional about the programs that we're doing to make sure that those programs are scalable. And so I am given the charge, Bob, thank you, for doing this in 3 slides. I am going to give you one example of partnerships, programs, and policies that we've been working on to address food insecurity in the interest of improving population health. And just for context, I want to mention that it is both true that food insecurity drives poor health in the United States and probably all around the world, but also that poor health in the US is really expensive. And so people, once they're chronically ill, are at higher risk of food insecurity because the illness itself increases your out-of-pocket medical expenses, which puts pressure on your food budget and also reduces your ability to maintain steady employment. So we're working in this circle of poor health causing food insecurity and food insecurity causing poor health. So let me start with an example of partnerships. Feeding America is the largest hunger relief organization in the United States. They are the umbrella organization over 200 food banks that provide service to about 46 million people every year through a network of 61,000 food pantries and meal programs. So incredible scope and scale. Their service area of Feeding America includes every single county in the United States. 46 million people they're serving every year. It's an enormous number. And historically, since the beginning of the charitable feeding system in the late 70s, early 80s, the focus has been on the distribution of calories because hunger was associated with inadequate access to calories. And Feeding America distributed tons and tons and tons of calories through their network, and their strategic goals had always been around distributing more pounds of food. And what we all probably understand as an ubiquitous cause is more pounds of food is not going to solve this problem. And so one of the ways we've been working is very intentionally with Feeding America, where I now have an official position as their senior medical advisor, to change our strategic goals. So the new strategic goals of Feeding America, again, it's touching 46 million people per year, is by 2025, in collaboration with our network and our partners, will ensure access to enough nutritious food. It's not just about the pounds, but what kinds of foods we're distributing, and make meaningful progress towards ending hunger. So what does that mean to have this kind of strategic goal and to turn it into practice within a large organization or a large partnership? I'm just going to give you 2 examples. One, this is a photograph of a pallet of soda, a picture that I took at a food bank in the Midwest. And as you can see, it's wrapped up, ready to go to whatever food pantry it will be distributed on to, except that it has a sticker on it. And if I blow up that sticker, you will see that that sticker says, expired, spoiled product for disposal, go to the garbage compactor. So this is an example of how, working through this large system, we can have hopefully a meaningful impact on some of these ubiquitous causes. And that's by leveraging our influence within these systems to try to develop policies that support better health. The second example is, you can all have an image in your mind of a food pantry where you walk up, you receive a box of shelf-stable food that has in it, historically, white rice, beans, peanut butter, and then you compare that to what food pantries all across the country are starting to look like more and more. And in California, they all look like this. Not all of them. Many of them look like this. And what we have done is really intentionally leverage principles of behavioral economics so that the healthier food, which we have enormous access to now as a food banking system, the healthier food is the appealing food to take. Why is that? You'll notice it's in boxes. It's in baskets, not these huge boxes where they used to be distributed from. It's at eye level. It's the first food you get to. It looks beautiful, and people come through the line and they take what they want. And then at the end, in smaller quantities, is the shelf-stable food that many, many food insecure households have access to anyway. This is the food, the expensive food, that's more expensive and more challenging for these populations to access. So one example of strategic partnership. What you might be thinking to yourself is that's well and good, but the truth of the matter is most people get their food at the grocery store, not at the food pantry, and I would say that is absolutely true. And if we're going to have a meaningful impact on this problem, we better figure out ways to engage the retail sector as well. And it is also particularly true in rural America because, will you keep an eye on time? Because I'll just talk forever.
Keep going, you're okay.
Okay. It's particularly true in rural America because even though we have 61,000 food pantries across the US and we have an entire secondary grocery market that exists in parallel to the retail market that's part of the charitable feeding system, Walmart can do it better, right? The corner stores and the Walmarts are everywhere. Everywhere has access to them. And the question is, why do we have to have this secondary system that we make marginally better for people who are food insecure and don't leverage the system that already exists? And the strategy that we have found to leverage that retail sector is by providing vouchers. And this is a program that we've developed here, originally called EAT-SF, where we provide vouchers. Now, there are many voucher systems all over the country that provide generally short-term vouchers that you can redeem at farmers markets. And the goal of this is different. The goal of this is to leverage the retail sector, to bring in the private sector. And to do that, those vouchers have to be redeemable at your corner store. They have to be redeemable at Safeway and at Walmart and at Target and anywhere else where people are likely to buy their fruits and vegetables. So EAT-SF, now known as Vouchers for Veggies because we're outside of San Francisco now, tries to do just that. How can we pull the private sector into solving this problem with us? The idea here also is that one part of the reason that healthy foods are not available in our lowest income neighborhoods is because there is inadequate money in the neighborhood to purchase those fruits and vegetables. It's a highly perishable product. You can't just throw them in to a low income neighborhood. If there's not adequate money in the neighborhood to buy them, they rot. There's no reason for the vendor to keep stocking them. Just as an example, since April of 2015, EAT-SF has put about $1.6 million directly into fruit and vegetable purchases in Tenderloin, South of Market, and Bayview, Hunters Point. And that makes a difference. That means that the grocery stores and the corner stores can stock more fruits and vegetables of a higher quality and a greater variety. And so that, we think, is really a way of transforming the retail sector in a way that will support population health. And then finally, getting a little bit to Dean's point, why are we working on policies here? Well, SNAP, formerly known as Food Stamps CalFresh in California, reaches 49 million people in the US. You can use SNAP benefits in every county in the US as well. And really, one of the things that we understand about SNAP is that it not only reduces food insecurity rates, but allows people, by augmenting their food budget, to purchase a more healthy basket of goods. And so the question is, we could leverage this for population health by supporting improved access to SNAP benefits, but we have this really challenging narrative. And so the question is, how can we change the narrative from a handout to worthy of investment, that this is an investment in our population's health? And these systems like SNAP are designed to support food security, and they do. They're not designed to improve health. But the truth of the matter is that we can document relatively easily that there are substantial healthcare savings that can happen with SNAP utilization. And so how can we leverage that? And how can we build the data towards improving policies around things like SNAP so that we can leverage them for improving health?